Hello everyone, myself Dr. Pallav Roy, third year general surgery resident at District Hospital Thyroid. So today we will be starting on topic thyroid. So before starting on the topic, I always say to everyone that behind every incision there lies a story. So behind thyroid also there was some kind of story before the starting of thyroid surgeries. So the name thyroid, it comes from a Latin word that means shield. So what happened actually that thyroid is a gland which is located in the front of the neck, which was thought to be acting like a shield to protect our neck, but that actually is not the case. So generally before the advent of new techniques, thyroid surgery was considered to be the one of the most challenging surgeries, with the highest number of deaths and mortality and morbidities after surgeries. But with recent advances and other techniques, sterility and all, we have come with we have come in such a manner today that we can do incisionless thyroid surgeries. There will be no incision, and still you can remove a thyroid gland. So that is the advancement of surgery that we are facing nowadays. So before starting the thyroid surgeries, we have to first see basics of thyroid anatomy. This will be a very detailed class, so it might take long time. You can fast forward it by watching it 1.5x or 2x, because I am going to explain it in details. So first, if you look at the thyroid anatomy, it is a butterfly shaped organ located in the front of the neck. So the general weight is around 25 to 40 gram, and in each thyroid there contains follicles. So the follicles are around 24 to 40 follicles present in a thyroid. And the functional unit. Suppose, what do you mean by functional unit? Suppose in a factory the functional units are levers and machines and equipments. So in thyroid 2, the functional unit, that means which actually functions the main action of thyroid, that is known as functional unit. So in thyroid, the functional unit is known as lobule. So lobule is the functional unit of the thyroid gland. So since it is a butterfly shaped organ, we can make it as a diagram. I am sorry for my horrendous diagram, but it is what it is. Anyways, so this is a schematic diagram of thyroid gland. So if you see the arterial supply of thyroid gland is this is called as right lobe. Suppose this is right side and left side. So this is right lobe, this is called left lobe, and this is called isthmus of the thyroid gland. So we have to see the arterial supply, the venous drainage, and nerve supply of the thyroid gland. These are the basics to know the thyroid anatomy, because in surgeries we have to ligate these vessels first before proceeding for surgery. So these are important structures. So if you see superiorly, the superior lobe of thyroid is supplied by, obviously, superior thyroid artery. Inferior lobe is supplied by inferior thyroid artery. So superior thyroid artery, it is a branch of external carotid artery, while the inferior thyroid artery, it is a branch of thyrocervical trunk. Similarly, this side also. Sometimes there is also one more branch called as thyroid ima artery. It is a direct branch from the arch of aorta, and its supplies goes through the thyroid gland to reach the isthmus of the gland. So this is the arterial supply: superior thyroid artery, inferior thyroid artery, and thyroid ima artery. which is a branch. Superior thyroid artery is a branch of external carotid artery. Inferior thyroid artery is a branch of thoracocervical trunk, and thyroid ima artery, which is a branch of arch of aorta, which goes to the isthmus. Similarly, if you see the venous drainage, so superior pole will be drained by superior thyroidal vein, which further drains into IJV, that is internal jugular vein, while the inferior pole of thyroid is supplied by inferior thyroid vein, which further drains into brachiocephalic vein. Right. There is one more vein that is known as middle thyroid vein. Like thyroid ima artery, there is also one more vein that is known as middle thyroid vein. It is only present in 30% of individuals. Right. So it drains directly into IJV. And what is the importance of this structure, this middle thyroid vein, is that it is the first vein to be ligated before proceeding for surgery. Fine. So this is the blood supply of thyroid gland. Now if you see the nerve supply of thyroid gland, so if it's a nerve supply, so the nerve supply is first is external branch of superior laryngeal nerve, which is also known as external laryngeal nerve. So it supplies the cricothyroid muscle. So as we all know from ENT, or if you are studying ENT, the cricothyroid muscle acts as a tensor of vocal cord. That means that it helps in high pitch sound. So if after surgery, if the patient is not able to shrill or have a shrill voice or have a change in voice, or is not able to produce high pitch sound, that means that this external branch of superior laryngeal nerve or external laryngeal nerve has been damaged. One more nerve supply is there, that is recurrent laryngeal nerve. This is a main nerve supply. So this is a recurrent branch because there are two sides of this, left side and right side. So left side winds around the arch of aorta. So we have to remember, left side is longer. So L for L. So left side is longer than the right side. So just because this left side is longer, that is why it is more prone for injury. So left side of left recurrent laryngeal nerve is more prone to injury than the right side, and right side winds around the subclavian artery. Which is shorter. So left side is longer while right side is shorter than the left side. But in 2% of patients, there is also presence of non-recurrent laryngeal nerve on right side, because it is associated with aberrant right subclavian artery. So see, so the functions of recurrent laryngeal nerves are it supplies a sensory supply below the cords. Cords means vocal cords. And also it supplies all the muscles of the larynx. except cricothyroid. So let us just revise the muscles of larynx. So we know now that recurrent laryngeal nerve supplies all muscles of larynx except that cricothyroid. So what are the other muscles of larynx? If you don't remember, then let us revise again. So laryngeal muscles are divided into intrinsic and as well as this extrinsic muscles, right? So intrinsic muscles we can see first is cricothyroid, second is thyroarytenoid, third is lateral cricoarytenoid, fourth is posterior cricoarytenoid, and fifth is that transverse and oblique arytenoids. While the extrinsic muscles of larynx are further divided into suprahyoid, that is above hyoid bone, that is, I have remembered like this one, like this mnemonic DSMG. So D is digastric, S is stylohyoid, M is mylohyoid, and G is geniohyoid. There is nothing conceptual in this, you have to mug it up. If you are a surgeon, you don't need to mug it up because you will see it directly in operation theatre. And the other type is infrahyoid muscles. So these are below hyoid bone. These are sternohyoid, omohyoid, sternothyroid, and thyrohyoid. We can see one thing. All these muscles are related to thyroid bone. So this means obviously it is related to suprahyoid and infrahyoid, that is this above hyoid bone, while this is below hyoid bone. So these are the muscles of larynx. So there are high chances that during surgery you can damage the recurrent laryngeal nerve, and if you damage the bilateral recurrent laryngeal nerve, then it can cause respiratory distress as well as death. So that means you have to take utmost precautions to preserve this recurrent laryngeal nerve. So there are few pointers to identify intraoperatively the recurrent laryngeal nerve. So few pointers are: first is tubercle of Zucker-Candle. So second is Berry's ligament. Guys, these headings are directly from Bailey and Love and Sybiston, so you can correlate with your books as well. It's taken from standard textbooks. Okay. So these three pointers are there which are required to identify for proper identification of recurrent laryngeal nerve to prevent the damage intraoperatively. So what is tubercle of Zucker-Candle? It is a posterolateral projection of thyroid gland. So suppose this is thyroid gland. Posteriorly there will be a projection that is known as tubercle of Zucker-Candle. So how this tubercle of Zucker-Candle is related to recurrent laryngeal nerve? So recurrent laryngeal nerve runs posterior to the tubercle of Zucker-Candle. So posteriorly, we can find the recurrent laryngeal nerve posteriorly to the tubercular Zucker candle. So this is important landmark to identify the nerve. Second is Berry's ligament. So Berry's ligament, this ligament is responsible for the up and down movement of the thyroid gland with deglutition. So as we all know that for examination of thyroid gland, the first thing, one of the most important tests that we do is we ask a person to swallow. If the swelling moves up and down with deglutition, that means it is related to thyroid gland. Otherwise, it is not. So this happens because of the attachment of Berry's ligament. So Berry's ligament is a condensation of pretracheal fascia. Guys, we'll discuss about the fascia of neck. There are many structures in some other class. Today we will be just focusing on thyroid gland. So thyroid gland is attached to trachea through the Berry's ligament. So recurrent laryngeal nerve runs through the groove, and hence it is most commonly damaged at Berry's ligament. So suppose this is a trachea, these are tracheal rings, and this is a thyroid gland. And so there will be attachment of condensation of pretracheal fascia, that is known as Berry's ligament. This, while moving up and down with deglutition, this thyroid gland also moves up and down with deglutition. Third is Behr's triangle. So Behr's triangle is a triangle that is formed by common carotid artery, inferior thyroid artery, and recurrent laryngeal nerve. It also acts as a guide to locate the recurrent laryngeal nerve. Because we can see in this triangle, recurrent laryngeal nerve is present here. So if you know the common carotid artery and the location of inferior thyroid artery, we can know the location of the recurrent laryngeal nerve. Okay. So these are the few topics that we have to know about anatomy of thyroid gland before starting the main topic of surgery, that is thyroid. So thyroid gland will generally present as swelling in front of the neck. So generally, while case presenting or while seeing a patient, we generally say the swelling present in the front of the neck at the region of the thyroid. So generally, thyroid gland presents as solitary thyroid nodule. And that is, clinically, there will be only one single nodule present in the thyroid gland that will be seen, visible or palpable, and will move up and down with deglutition, as we have discussed before, because of the attachment of Berry's ligament. So, for evaluating any case of solitary thyroid nodule, there is one algorithm that I will say later. So, investigations, what we have to do first is, so let us discuss the algorithm for discussion of solitary thyroid nodule. Because solitary thyroid nodule will present as symptoms of hyperthyroidism or hypothyroidism. Hyperthyroidism features are that it will present as increase in, we can remember like this, that it can present as a symptom of increase in basal metabolic rate. So in that case, there will be weight loss, there will be heat intolerance, there will be oligomenorrhea and other features. While hypothyroidism will present as symptoms of low basal metabolic rate. So that means there will be weight gain while normal appetite, there will be depression, there will be polymenorrhea or same polymenorrhea, like that. So we have to work up any case of any case of solitary thyroid nodule. So workup will be like go like this. There's an algorithm. We'll start with this. That it is taken from page number 892 of Cyviston. You can go check it out. So suppose there is presence of thyroid nodule. First investigation we'll do is history and physical examination. Then we'll measure the T3, T4 and TSH. This is a thyroid profile test or known as TFT. So this is the main measurement that we have to do, and according to this we have to follow the protocol. TSH can be either low or high. So suppose if there is low TSH, that means first we have to, I'll tell you that what is the significance of T3, T4 and TSH. So T3, T4, TSH. So if T3 is low, T4 is low, but TSH is high, we call it hypothyroidism. If T3 is more, T4 is more and TSH is less, we call it hyperthyroidism. These are both clinical. While if T3 is normal, T4 is normal and TSH is low, then we call it TSH is high, call it a subclinical hypothyroidism. Subclinical, while these are all clinical. Anyways, so if there is low TSH, as we have seen, if there is low TSH and the T3, T4 is higher normal, then it is a case of hyperthyroidism. So in this case, we'll do one radioisotope scan. I'll tell you about radioisotope scan later. In radioisotope scan, you can get either a hot nodule or a cold nodule. So, how do we do this radioisotope scan? We do it by two methods are there. That is a technetium 99 scan, while another method is there is a iodine 123 scan. Technetium 99 scan only tells about uptake, while iodine 123 scan tells about uptake plus organification. So suppose right. So in case of normal thyroid gland, there will be normal uptake while doing this technetium 99 or iodine 131 scan. While in case of cold nodule, the uptake will be normal in the whole gland or more in the whole gland, while there will be a single spot where there will be no uptake of the isotopes. This is known as cold nodule. Similarly, in case of hot nodule, the gland will not uptake that radioisotope, but this lesion or mass or nodule will uptake it more. That is known as hot nodule. So in cold nodule there will no uptake, while in hot nodule there will be more uptake of this isotope scan. While in case of Graves' disease, there is primary thyrotoxicosis, there will be diffuse uptake of that isotope. There will neither be any hot nodule or cold nodule. there will be diffuse uptake of this isotope. So if you see, this is a normal gland, this is a cold nodule, this is a hot nodule, and this is a diffuse uptake, that is in the case of Graves' disease. So in cold nodule, the chances of malignancy, that is cancer, of CA is 20%. While in case of hot nodule, the chances of malignancy is only 2 to 4%. Right. So this is the isotope scan that we do in case of hyperthyroidism, in case of radioisotope scans. Now we'll come for high TSH or elevated TSH. That means the patient is suffering from hypo. So in this case, we'll first go for ultrasound of the neck. Right. So ultrasound, in this ultrasound, there is one scoring system that we know is called as TIRADS. TIRADS scoring system. So in TIRADS, there is TIRADS 1, 2, 3, 4 and 5 that we'll discuss later. Right. So next page we'll go. Now we'll discuss about TIRADS. See guys, these all are previous year questions as well as very hot topics that can be asked in your PG bar professional exams bar your residency. So TIRADS, the full form is Thyroid Imaging, Reporting and Data System. So TIRADS 1, 2, 3, 4 and 5. So 1 is benign. 2 is not suspicious of malignancy. 3rd is mildly suspicious of malignancy. 4th is moderate suspicion. 5th is highly suspicious of malignancy. So this is thyroid imaging, reporting and data system. Based on this, we will go for FNAC. So this TIRADS is based on the ultrasound imaging, USG imaging. So now we have to divide it. That what are the features that can tell us that it is either a benign or a malignant nodule. So there might be some difference that can be told via the ultrasound scan that it is benign or malignant. So if we differentiate between these, so in case of benign lesion, the nodule will be iso or hyperechoic, while in case of malignant it will be hypoechoic. Hypoechoic means the nodule will have lesser density than the surrounding. So suppose this is a nodule and this is a normal thyroid parenchyma. So this will have, the thyroid parenchyma will have more density. In case of ultrasound we call it echoic. In case of CT scan we call it density. While in case of benign, it can be hyperechoic or isoechoic, that is similar to the thyroid parenchyma or more than thyroid parenchyma. Second is macrocalcifications present in benign, while microcalcifications in case of malignancy. So it will be bigger calcifications, while in case of malignant it will be very fine and very small, the calcifications. Borders. In case of malignancy, the borders will be regular. So suppose this is the thyroid gland, this is thyroid parenchyma and this is a nodule. So nodule will be fine border. while in case of malignancy, the borders will be irregular. We cannot make it out. Fourth is infiltration. So this is a common feature of every malignancy, that it will infiltrate the surrounding structures until and unless it is a in situ carcinoma. In situ carcinoma, there is no breach of basement membrane, but in case of malignancy, there will be breach of basement membrane, and that is why it will infiltrate other structures. So in case of benign, there will be no infiltrative margins. Infiltration negative. While in case of malignancy, there will be infiltration will be there. In case of benign nodule, there will no lymph node involvement. While in case of malignancy, there will be presence of lymph nodes. Mainly level 3, level 4 and level 6. Some cases level 2 or level 5 might also be involved. So these are the difference between benign and malignant features of a thyroid nodule. So based on these features, we'll further go for the investigation of choice for any thyroid swelling, that is FNAC, fine needle aspiration cytology. So in case of thyroid nodules, Bethesda system of classification is used for FNAC criteria. This is also taken directly from Bailey and Love. So we can divide it as Thigh 1, Thigh 1C, Thigh 2, Thigh 3, Thigh 4 and Thigh 5. Thigh 1 is non-diagnostic and Thigh 1C is non-diagnostic. C for cystic, right? Thigh 2 is non-neoplastic. Thigh 3 is follicular. But in case of FNAC, it cannot differentiate between adenoma or carcinoma. So just follicular. It can be follicular adenoma or follicular carcinoma. Thigh 4 is suspicious of malignancy. Thigh 5 is malignant. Right. So if we get Thigh 1 or Thigh 1C, then the standard criteria is that we have to repeat FNAC. Suppose this FNAC was blind, that is not under visualization or any ultrasound. So if we get Thigh 1 or Thigh 1C, then we have to repeat FNAC by ultrasound guided. Otherwise there is no use. Thigh 2 is non-neoplastic, and Thigh 3, Thigh 4, Thigh 5, starting from Thigh 3 up to Thigh 2, we can manage the patient conservatively, just by aspiration or by regular monitoring of the patient. While starting from Thigh 3, that is follicular, we have to start with surgeries. So Thigh 3, either adenoma or carcinoma, we have to do hemithyroidectomy. That is the surgery of choice. And Thigh 4 and Thigh 5, we have to go for total thyroidectomy. So these are the two criteria for FNAC and TIRADS. So if you come to this staging, again we have discussed about TIRADS 1, 2, 3, 4 and 5, and after this TIRADS, I have said it that we will go for FNAC. This we will go for Bethesda system of classification. And according to this Bethesda system of classification, we will further plan if the patient requires operation or not. So this is the thyroid investigations. Now these are the basic investigations. Suppose we are suspecting any further extension to the neck or to the thorax, then we have to always do for CECT to look for neck and thorax. In case of large goiters, large swellings, one more thing, that is retrosternal goiter, right? So in these two cases we have to go for CECT. So we saw, if we revise again, the thyroid swelling, first workup is, first we have to go for history and physical examination, then T3, T4 and TSH. Followed by that, if TSH is low, then it is known as hyperthyroidism. Then we have to go for radioisotope scan. In radioisotope scan, it can be hot nodule or cold nodule. This is the hot nodule and cold nodule that I have told you. Further, if TSH is high, that means it is a case of hypothyroidism. Then to go for USG neck, and according to that we classify it as a thyroid scoring system that I have told you. And further, after this thyroid scoring system, we have to go for FNAC, and then we have to classify it as Bethesda system of classification. So these are the classification of thyroids as well as FNAC. And then we have to go for CACT. Now, if you go to surgeries of thyroid gland, so first we have to see the indications of thyroid surgeries. We cannot simply just tell the patient that you have goiter, you need to undergo surgery. No, there are certain indications. So in case of, I've told you already, in case of FNAC, the finding is from thigh 3 to thigh 5. Why thigh 3? Because it was, if you remember, it was follicular. It can be adenoma as well as carcinoma. So we don't know, so we have to go for surgery. And thigh 5 is malignant only, so we have to go for total thyroidectomy. Second is clinical suspicion of malignancy. So what are the clinical suspicion? Age. The higher the age, the more chances of malignancy. Male sex is high risk factor for malignancy. Heart texture. As you know by the thumb of rule that any stony heart swelling, mostly it is a cancer. So we need to go for surgery. Fixity to skin. Fixity to not skin only, any other structures. So as I told you before, that one of the hallmark of cancer is that it is infiltrative, that it can infiltrate the other structures. So the tumor deposits will go and infiltrate the other muscles or the skin, which will cause a fixity to the skin or other structure, which raises a suspicion of malignancy. Fifth is RLN palsy. Again, same concept, that the tumor deposits will go and affect the recurrent laryngeal nerve, which can cause a recurrent laryngeal nerve palsy. In some cases, I've seen already that there is a severe dysphagia and then dysphonia and all. So it can cause recurrent laryngeal nerve palsy as well. Sixth is lymph node involvement. So as I told you before in this slide, that lymph node will be positive in case of malignancy. So if there is a lymphadenopathy or this lymph node involvement, we can suspect it is a malignancy. And if it's a recurrent cyst, generally in simple cyst we don't operate, we just aspirate if it is more than 5 ml. But in case of recurrent cyst, there is suspicion of malignancy, then we have to do surgeries. This is a suspicion of neoplasia. Third is toxic adenoma. So there will be toxic symptoms of thyroid. This is a very big chapter, so I'll tell it later in some alag classes. Fourth is pressure symptoms. What are pressure symptoms? So here is thyroid, here is trachea, and here is esophagus. So if the goiter is very big, it will compress the trachea, which will cause, if you know, difficulty in breathing. It can also compress the laryngeal muscles, which can cause vocal cord problems, that is speech problems. While this is also known as scabbard trachea. That will be hoarseness of voice if you just stretch the trachea. Second is esophagus. If it is very large goiter, then it can also compress the esophagus as well. If it compresses the esophagus, there will be a symptom of dysphagia. So this is also an indication of pressure symptoms, that for this we need to have surgery to be done. And fifth is cosmetic. There are many patients who will come that my thyroid gland is so big, it is looking odd and all. So for that reason we need to do surgeries. That is completely up to the patient. So these are the indications of surgery. So now we'll see the surgeries of the thyroid gland. Surgeries of thyroid gland. So generally, there are 4 types of surgery that we do generally. So suppose I'll make the 4 thyroid glands. It'll be easier for you. Sorry for my horrendous handwriting and my horrendous diagrams. This is the best I can do. So, so I'm sorry, this is not coming properly. Yeah, still not proper, but I cannot do anymore. So first is hemithyroidectomy. Hemi. So hemi means removing one gland, one lobe. So this is, as in the first slide I've told you, this is the right lobe, left lobe and isthmus. Similarly, so according to this, if we go to the anatomy, this is the right lobe, left lobe as well as isthmus. So in hemithyroidectomy, we remove the one lobe plus isthmus, right? So we'll remove this. Suppose there is a right-sided nodule or right-sided suspicion of malignancy. So we'll remove this right lobe as well as isthmus. So this is hemithyroidectomy. Now second comes, so this is known as lobectomy plus isthmectomy. Second comes subtotal thyroidectomy. Subtotals means we'll remove both lobes of thyroid plus isthmus, but we'll leave around 5 to 8 grams of thyroid tissue on each lobe. That is around 1 thumb of area. So in this case, we'll remove this lobe of thyroid plus isthmus plus the left lobe of thyroid, but we'll spare this part and this part. So this 5 to 8 grams of thyroid tissue is left on each lobe. This is known as subtotal thyroidectomy. While third type is near total thyroidectomy. That means that you will remove one lobe completely, and we'll remove the other lobe as well, but we will spare around 4 grams of thyroid tissue on one lobe only. So in this case, there was both lobes we have spared, while in case of near total thyroidectomy, we have spared only one lobe, little bit of thyroid tissue. And fourth is total thyroidectomy, that is, we'll remove the whole of the thyroid gland. So these are the 4 types of surgeries that we generally do in case of thyroid gland. So every incision and every surgeries comes with an complication. So thyroid is no less and it is no different. So what are the complications of thyroid surgeries? So we can divide it as early, post-operative and late. Intraoperative, immediate post-operative and late. So if we start with intraop, there can be bleeding due to, if you do not like it, if you remember my first slide, then I have told that we have to always ligate the middle thyroid vein first before proceeding for surgery. If you don't ligate middle thyroid vein, then we can encounter with a torrential bleed. Don't ligate middle thyroid vein. So second is immediate post-op. It can be further divided into primary hemorrhage as well as reactionary hemorrhage. Primary hemorrhage is also due to the same cause, that is non-ligation of the bleeding vessels. Reactionary hemorrhage, which can cause one of the deadliest complications of surgery, thyroid surgery, that is a tension hematoma. So the symptoms of tension hematoma will be that after surgery the patient will have difficulty in breathing, and the size near the operative site will increase suddenly, and there will be no decrease. In this case, we have to the treatment is immediately we have to remove the sutures. Remove sutures and drain the hematoma. It can be done in ward only, or we can done in OT. And after this, we have to shift the patient immediately to OT and do the ligation of the vessel that has not been ligated properly. It is a deadly complication if you don't intervene in correct time. Third is injuries to nerves. Nerve injury. As I've said in my second slide, that there are two nerves that are most important, that is superior laryngeal nerve, that is the external laryngeal nerve and recurrent laryngeal nerve. So as I told you, the external laryngeal nerve is a tensor of vocal cord. So it helps to produce high pitched sound. So if there is a damage to external laryngeal nerve, it can lead to hoarseness of voice, as the patient is not able to produce high pitched sound. It is not a life-threatening complication. This will be just a change in voice. While in case of recurrent laryngeal nerve, it can be further divided into unilateral damage and bilateral damage. So in case of unilateral damage, there can be only symptoms of hoarseness of voice, nothing else. While in case of bilateral, it can lead to disasters, because the vocal cords will come completely adducted like this, and it will cause complete obstruction of the respiratory tract. This will cause severe respiratory distress, which is life-threatening. Since the vocal cords cannot move, there will be aphonia, that means you cannot produce any sound, and aspiration, because you cannot swallow your saliva. So unilateral will cause hoarseness of voice, and bilateral is life-threatening, which will cause aspiration. Now, immediate post-operative. First is post-operative respiratory distress. Right. This can be due to, number one, due to extensive dissection, it can cause edema in the larynx, which can known as laryngeal edema, which in itself is not a very serious complication, but you have to treat it. Second is, as I told you, tension hematoma. You have to immediately evacuate it. Third is laryngomalacia. Fourth is, as I told you, bilateral laryngeal nerve palsy or bar injury. Unilateral, nothing, it will cause nothing. And fifth is hypoparathyroidism. I'll tell you why. So, parathyroid glands are just located in the inferior pole of the thyroid. Okay. It can sometimes be confused as lymph nodes and can be dissected, which will cause hypoparathyroidism. Right. So the main symptoms of hypoparathyroidism will be that due to, suppose here there is supralaryngeal nerve, supralaryngeal artery, and there is inferior artery. Inferior thyroid artery. So this inferior thyroid artery, which also gives branches to the parathyroid glands. Suppose there is a vascular insult to the arteries. Suppose we ligate the artery here instead of ligating here, we're ligating here. So you see, the vascular supply of the parathyroid gland is also getting stopped. So that means the parathyroid gland will also not reach the blood supply, and then it will cause the damage to parathyroid gland, which will further lead to hypoparathyroidism. So, but it doesn't occur immediately. It generally occurs 2 to 5 days after surgery. If you are using old Banian Love, that is 27th edition, it is given as 48 to 72 hours, but in new edition it is given as 2 to 5 days. So the earliest symptom will be perioral numbness, that is around your lips or around your oral cavity you will not feel anything, followed by tetany, followed by the dreaded complication, that is respiratory muscle paralysis. Right. So there are two important signs in case of hypoparathyroidism that are important to elicit, that are told to every postgraduate to look for after a thyroid surgery. First is Shostak sign. Second is Trousseau sign. Shostak sign is while you tap the facial artery, it will cause twitching of the facial muscles. While in case of Trousseau sign, there will be carpopedal spasm. That means what we do is we will generally inflate the BP cuff 20 millimeter above the normal blood pressure, and will keep it for 1 to 2 minutes or sometimes 5 minutes as well. So there will be carpopedal spasm, there will be spasm of the hand, and this will show us the sign of hypoparathyroidism due to decrease in calcium. Ism positive if there is carpopedal spasm. Right. So the management of hypoparathyroidism in case of thyroid surgeries is like we have to monitor the symptoms of tetany or any subsection or Trousseau sign first, and then we have to measure the serum calcium level. But we cannot wait for the serum calcium level because this is a life-threatening condition. So you have to immediately intervene before the results of the calcium levels. So if symptoms are minor plus serum calcium is more than 8 deciliter, we will just give oral calcium and oral vitamin D3. While in case of major symptoms like respiratory muscle paralysis, tetany and all, and if serum calcium which is less than 8 gram per deciliter, we will go for IV calcium gluconate, oral calcium and oral vitamin D3. So these are the post-op complications. Now we'll go for late complications. The late complications are permanent hypoparathyroidism. That means if there is a requirement of calcium supplements for more than 1 year after surgery, that is a permanent hypoparathyroidism. Second is hypothyroidism. Obviously, if you remove the thyroid gland, there can be chances of hypothyroidism. Third is formation of keloid. And fourth is recurrence. Fifth is can also form as fistula or sinus. It can also form suture granuloma, right? So this was a simple overview of thyroid gland and surgeries. Next class we will be taking on thyroid cancers, and in the furthermore classes we will go for benign conditions of thyroid. Thank you for listening. If you like it, you can subscribe to my channel. Thank you.